Oh, we're live. We're live, Patrick.
Hello, everyone, and happy to welcome everyone to this very interesting session 2F on this poster session on relevance, different sources of evidence, and sharing of knowledge. I think we have all the speakers here, or at least we have their recorded sessions. So I would just start running down the speakers, and each speaker has 3 minutes to give their presentations, and then there is time for questions. So the first poster is on using e-COVID rec maps for the development of rapid guidelines. And this will be presented by Deborah Dalmas-Graf. She is a researcher at the Hospital Moillos de Vento. She has a bachelor degree in biomedical sciences and master's degree in epidemiology. And she currently works with the guideline development for the Brazilian Ministry of Health. Deborah, you have the floor.
Hi, thank you, Patrick. I'll be presenting my screen now, so just 1 second. Can you guys see it?
Yes, we can.
Okay, so hello, my name is Deborah. I'm a Brazilian researcher, and I'll be presenting my work, which is using a RAC map for the development of rapid guidelines. So we all know that guideline development can take time, can take a lot of resources, and under public health emergencies such as the COVID-19 pandemic, we need promptly available evidence-based guidelines in order to provide recommendations so that society can be better taken care of, and clinicians and physicians have a guide or a document to go to. So our goal was to develop a trustworthy guideline within a short time frame in order to make it available as soon as possible. And in order to do that, we used the graded development approach, which allows us to adapt, or develop a de novo recommendation. We also used a platform called the COVID RAC map, which it's a catalog that maps all the COVID-19 related recommendations that have been issued from different international societies, such as WHO or the American Society of Infectious Disease and others. And we extracted the recommendations that were regarding hospitalized patients, pharmacological treatment of hospitalized patients. We reviewed those recommendations, presented them before a panel, and we issued our own towards the Brazilian setting. So we also conducted additional online searches in order to find newly available evidence that wasn't yet incorporated into the guidelines that were already developed. And in case of adoption of a recommendation, we chose the most recent assessment of the technology of interest that we could find. So as a result, we ended up finding 10 different guidelines, which assessed 58 technologies. We assembled a group of 20 physicians and 7 methodologists. We met 7 times for approximately 2 hours in a time frame of 5 weeks. And we ended up issuing 15 recommendations regarding 12 different technologies for the Brazilian setting. 3 of them were adopted, 10 were adapted, and 2 were de novo recommendations. So our goal was to provide a shortcut, which could still be very reliable and evidence-based, in order to provide better care for patients and make it available as soon as possible. So we are currently developing another guideline for the outpatient setting, and we are using the same methodology in order to make it as soon as possible. So I guess that's it. I'm sorry if I spoke too fast, but I can answer any questions if you have now.
Okay, so I think I understand that the time is really tight, and thank you for your sharp presentation right on time. I don't see any questions in the comments, but the questions may come further. So for us to gain time, we could move on. I would also have some questions at the end if we don't have any from the presenters. Let me just quickly check in the discussion. Sometimes some questions go into the discussions. I don't see any in the discussions. So we'll just move on to the next presenter. The next poster is on the development of the novel clinical practice guidelines for proton beam therapy in the oncology treatment of children based on an identified health technology assessment in the context of very low quality evidence and lack of RCTs. And this very interesting topic is going to be presented by Lucia Kantorova, and she's a guidelines methodologist at the Tech Health Research Council. So Dr. Lucia is a core staff of the Tech Center for Evidence-Based Healthcare and Knowledge Translation, the umbrella organization for Masaryk University Grade Center, JBI Center of Excellence, and the Cochrane Czech Republic, Cochrane Center at Czech Republic. She's working as a senior methodologist in several guideline development groups within the Czech National Clinical Practice Guideline Project. Her academic area of interest is great for public health. She's involved in development of COVID-19 Living RecMap. She's a member of the Palacky University Center for Evidence-Based Education and Arts Therapy, where she helps train researchers. So Lucia, you have the floor.
Thank you very much, Patrick. It is my pleasure to introduce the topic of how we developed a clinical practice guideline for proton beam therapy for the oncology treatment of children in the Czech Republic in the context of very low quality evidence. The project has been developed as part of the Czech National Guideline Development, and it was funded by these two agencies, and the authors would like to declare their membership in the following organizations. The guideline aimed to assess the benefits and harms of PBT in comparison with other types of radiotherapy. It was commissioned by the Ministry of Health of the Czech Republic. And just to give you a little bit of a background, the proton beam therapy there are two privately owned centers in two major cities in the Czech Republic, and it's being used as the first line of therapy sometimes, and it's even being reimbursed from public health insurance without any clear link to evidence. So you can see how we developed the guideline on the following portal. We searched for guidelines in September 2019 and found 0 results. We also searched for health technology assessments and systematic reviews and found 1. And we have found 1 additional cohort study in February 2020. So the clinical practice guideline was developed based on this 1 health technology assessment and 1 additional study. When we again searched for guidelines a few months ago, actually we found that there is 1 more. One has been developed in the meantime on the same pool of evidence, which basically stated that the PBT can be publicly funded. And these are just the sources of guidelines and the sources of systematic reviews that we searched. And to summarize the evidence, there were no RCTs, and there were very few comparative studies and 78 case series. The risk of bias was very high, and the overall certainty of evidence was very low. The evidence was even missing for some of the tumor types, as you can see here. The panel met last week, actually, and formulated recommendations even in this context of very low evidence. It was a conditional recommendation suggesting to consider using PBT as an alternative to photon radiotherapy. And there were actually no recommendations developed when there were no case series identified for some of these tumor types. Thank you very much for your attention, and I'm very happy to answer any questions.
Thank you very much, Lucia, for also keeping strictly to the time. Let me quickly see if there are any questions in the discussion board. There are no questions in the live question and answers. There are no questions in the discussion forum. So let's see. So I think the question is a question for you, Lucia. So first, the question is from Simon van Kavenberg, and compliments you for the good presentation. And is asking, can you expect to have more evidence in the near future regarding this topic? Can you please respond to that, Lucia?
Yes, of course. Thank you for the wonderful question. Actually, there are some RCTs registered on clinicaltrials.gov, so which should be finished in several years. So the panel actually discussed what should be the date for updating or for going through the evidence again, and it's been set for the end date of the RCTs that are planned at the moment. So several years, it seems.
Okay, all right, thank you. Another question for you from Lily Way says, compliments you for your presentation and ask, how did you deal with the high risk of bias?
The high risk of bias was sometimes connected with the design of the studies and the methodological issues there. And basically it was, we used grade to grade the certainty of evidence, and it was downgraded by 1 and most of the time by 2 points, leading to very low certainty of evidence.
Okay, thank you. Let me just quickly double check. No more questions for you there. Okay, so we'll move on to the next speaker, but just hold on because some questions could come up further. I'll call you back to respond to them. So the next poster is on talking what evidence we can get, designing clinical guidelines for personal protection equipment used during COVID-19 pandemic. And this is going to be presented by Brea Kunzler. She's a research fellow at the National COVID-19 Clinical Evidence Task Force. So Dr. Brea is a senior evidence officer with the National COVID-19 Clinical Evidence Task Force and a research fellow in behavior change at Behavior Works Australia. Brea works with a wide team of guidance development and clinical experts to create living guidelines related to the treatment and management of people experiencing COVID-19. These guidelines are freely available to guide clinical decision-making at covid19evidence.net.au. And there's also a Twitter handle at evidencecovid19. Brea, you have the floor, please.
Thank you, Patrick. Hello, everyone, and thank you for taking the time to attend this session and also view my poster. Before I begin, I'd like to acknowledge the traditional owners of the lands in which we all meet today. I would also like to pay my respects to elders past and present. So, as Patrick said, my name is Brea Kunzler and I'm a Senior Evidence Officer with the National COVID-19 Clinical Evidence Task Force. In brief, the task force was established in Australia in 2020 to collate and evaluate evidence emerging during the COVID-19 pandemic on topics related to COVID-19 management. Today, specifically, I will be outlining some work we did in the space of personal protective equipment, or PPE, used by healthcare workers. So healthcare workers in Australia are required to wear PPE to protect themselves from SARS-CoV-2 infection while at work. Currently in Melbourne, Australia, we are experiencing a peak in COVID-19 cases, and we're also in the process of relaxing movement restrictions. So because of this relaxing, we anticipate many more people infected with SARS-CoV-2 to present to hospitals and medical care, but also into the community healthcare organisations. So this not only increases the workload of our healthcare workers, but also puts them at high risk of infection themselves. So the task force was commissioned to produce recommendations on what PPE healthcare workers should use to most effectively protect them from SARS-CoV-2 infection. So we did this by first creating a panel of experts from areas such as occupational health, medicine and engineering, who were able to provide context around the clinical use of PPE. With their guidance, we found an important question needed to be asked: what respiratory protection is best to protect our healthcare workers from SARS-CoV-2 infection? N95 respirators or surgical masks? We engaged a search specialist and a team of evidence officers to search for published evidence in this space. who then screened all identified evidence and summarised all that was relevant to the question. These summaries were reported back to our expert panel for deliberation. In summary, although we obtained 21 full texts, most were of low quality and observational in nature. I think we have one RCT. This possibly reflects the speed in which the research was conducted, where time to plan and conduct controlled trials was lacking, but observational data was either available to be analysed already or easily obtainable. Because of the lack of strong evidence, the panel decided that only consensus recommendations were to be made, so recommendations based a lot on clinical experience, and that therefore our recommendations were then used to create a flowchart, which you see here. So this flowchart is open access, and so are the guidelines, and they're available on our website, which is at the bottom of this poster. So for convenience, unfortunately this is a bit blurred, but for convenience you can see our flowchart here. We produce these flowcharts to support clinicians and other stakeholders to implement the recommendations on the ground or in practice. Overall, this flowchart suggests that N95 respirators should be used with protective eyewear and other PPE like gown and gloves when working with patients diagnosed with or highly suspected of having COVID-19. Here's that website I mentioned earlier. Thank you for your attention today, and please feel free to contact me within the session or afterwards with any questions.
Thank you very much, Brea, for your presentation. I'll quickly check. I think there are some questions for you. So there is a question for you from Simon van Kavenberg, and he says from Belgium, he compliments you for your presentation, and then he goes on to ask, how do you see the integration of patient values regarding this topic and difficulty that exists globally due to fake news regarding this topic? Can we still rely on patient values in that case? Sorry for this complex question, but I'm curious how you tackle this. Thank you for your reply. Brea?
Thank you very much for the question. It's a fantastic question and very relevant. When we produce our guidelines, we actually engage consumer panels. So not only patients, but also clinicians. So in this case, for the wearing of PPE, we spoke a lot to the people experiencing the wearing of the PPE, so healthcare workers, but also we did have some conversations with patients to understand their experiences around working with healthcare workers and the sort of PPE that they expect to be worn. So those sort of considerations from the healthcare worker perspective and also the patient perspective are taken into account when creating the guidelines. And you'll see on our guidelines online that there is a section where we talk about the values of the community and the consumer and how they inform the overall recommendation. So we take that into account by running separate panels and presenting our guidelines and presenting flowcharts and getting their feedback and commentary.
Okay, thank you, Brea. Simon, I hope that covered your question satisfactorily. Please feel free, if you have more questions, to throw them into the live Q&A. I'll take them to the speakers. So there is no question in the live Q&A nor in the discussion board. So I will quickly go on to the next poster. So the next poster is on managing overlap of primary study results across systematic reviews, practical considerations for authors of overviews of reviews. And this is going to be presented by Carol Looney, who is a postdoc fellow at the Unity Health in Toronto. So Dr. Carol is a methodologist with the knowledge synthesis team at Unity Health Toronto and an affiliate with UBC. She specializes in research synthesis methods and critical appraisal of reviews, network meta-analysis, and overviews. Her current research focuses on the development of a risk of bias tool for network meta-analysis and methods issues in clinical practice guidelines and overviews. She completed her PhD as an epidemiologist at the Cochrane, Australia. She's a member of several methods groups at Cochrane, academic board advisor at the researchsquare.com, an academic editor for PeerJ. Her list of publications can be found at her at scholar.google.com citations. Carol, you have the floor. Thank you.
Hi, Patrick. I thought I had recorded my my presentation. So is that on your?
Yes. Okay. If you have your presentation recorded, I think Fiona will run it for us. Thank you, Fiona.
Perfect. Thank you. Hello, my name is Dr. Carol Lenny, and I'm presenting on behalf of my co-authors today our paper on managing overlap of primary study results across systematic reviews, practical considerations for authors of overviews of reviews, also called meta-reviews or umbrella reviews. Our objective was to describe methods to manage overlap of primary study data across multiple systematic reviews on the same topic, and discuss limitations, efficiency, usability, and resource use. So, overviews of systematic reviews synthesize the results of systematic reviews, much in the same way a meta-analysis synthesizes the results of randomized control trials. Overviews with multiple systematic reviews on the same topic often contain overlapping data from the same included primary studies. As an example, in Figure 1, shown here at the bottom left, middle left, we have 3 reviews, each containing randomized control trials, shown by the green tick marks. Review 1 contains 3 trials, Mitchell 2007, Henry 2008, and Nguyen 2018. Review 2 has 4 trials, and Review 3 has 3 trials. The trial by Henry 2008 overlaps across the 3 reviews, and the trial by Nguyen 2018 overlaps across Review 1 and 2, shown here highlighted in yellow across the columns. So why is overlap a problem? So overlap is a problem of precision. Overlap in effect estimates from meta-analyses give undue statistical weight to the duplicated studies and produces overly precise effect estimates. For example, duplicated sample sizes and treatment events produces risk ratios with narrower confidence intervals and more precise estimates. So what methods are used to deal with overlap? So authors could use one or more of these methodological choices. They can select one systematic review using eligibility criteria. For example, choose one high-quality systematic review. They can visually present overlap, such as we did in this Figure 1, and quantify the amount of overlap. They can also select one or more systematic reviews at the data analysis stage. For example, the systematic review at the highest quality and the most trials. So we learned a few lessons. First of all, there's no standard methodological approach to deal with overlap, as multiple approaches can be used sometimes in combination. Overlap should be dealt with at the outcome level and not at the systematic review level. Choosing one systematic review may not represent the totality of the evidence on the topic, and a loss of data may result. And including all systematic reviews will be a challenge when analyzing a large amount of review data. So I thank you for your attention, and I welcome any questions.
Hi, Fiona. Not sure. Maybe this hit the 3 minutes limit. Maybe this is why this went off. Fiona, can you advise?
It was finished.
Oh, it was finished. Okay, great. Okay, so thank you very much, Carol. Let me see if there are some questions for you. Lots of questions have piled up for Brea. I do see some questions where the author, the presenter has not been identified, but Carol, you do have a message from Donald Nicholson. It says, brilliant subject, Carol. Fully agree from their own experience. There is another one here. What about reanalyzing all systematic reviews to include all trials? Of course, it is difficult to do so because disappointingly, systematic reviews do not routinely publish the data in a machine readable format using the standard IDs for trials and standard terminologies for effects estimates and other variables. I'm not sure if this is directed to Carol or to another participant. Okay, Carol, please.
So in my topic, basically when I'm proposing a method where if you're doing a guideline and you have multiple systematic reviews on the topic, what do you do? Because then you'll have these same systematic reviews with kind of similar trials, right? Those trials are going to be overlapping. So that's a big problem because if you have overlapping trials, there's going to be a problem of over precision. So here, what do we do about this? And I think the person asking the question was saying, okay, what about just taking the unique trials out of those systematic reviews and doing a new meta-analysis? And that's a great thing that you can do. You could definitely do that. I mean, it does take work. It'll take more work, but that will solve that problem of overlapping trial data for sure.
Okay, thank you. So there's another question for you from Therese Christine, and she says, with respect to overlap, do you agree that corrected covered area is a promising method?
Well, actually, so I work with the author, the lead author on that corrected covered area, Dawood Pieper, and we've done some testing, some sort of informal testing of the corrected covered area. And I don't want to speak for him. I just want to speak for myself and my own opinion. But I believe that it's a hard. The corrected covered area is hard to interpret, and I personally, and it depends on the clinical topic as well, like what kind of like corrected covered area overlap measure you're going to find. So I personally wouldn't go that route. I would personally just try and do a matrix of studies, see the amount of overlap, see if it's going to be just. You are the expert in that topic. You're an expert in the condition that you're studying. So I would definitely look at yourself and make your own judgment about that.
Okay, thank you. Another question from Therese Christine. Great presentation about overlap. Are there any ways for dealing with this in the summary of findings table?
Unfortunately, no, not yet. So, but there is a statistical way there's a few statistical ways that you can combine the systematic reviews if you have a statistician in your group, and some of my papers outline that actually. However, if you can't go that route, then there is no real way to do a grade approach and then a certainty of evidence assessment, unless you do the pick out the unique trials and then do, like, for example, a grade assessment yourself.
Okay, so we also had a series of comments from Donald and a question. Donald was interested in connecting with you to talk more about the topic, but he also adds that, do you think the problem of garbage in, garbage out is being replicated at a systematic review level?
Of course, it's a problem with every evidence synthesis type, is that you have to just take the trials that are out there, right? And a lot of the trials are going to be low quality trials, but you still have to work with them. And so what we always suggest doing what's called a sensitivity analysis, where you group the trials at low risk of bias, and then you group the trials at high risk of bias, and then you see what the difference in effect estimates is. And typically, the low risk of bias trials will have overinflated effect estimates where, the treatment is great, and the reason why the treatment is great in these low risk of bias trials is because there's a lot of bias, a lot of confounding, a lot of noise in those trials. So we have to take that into consideration, and really we want to base our findings on the high risk of bias trials as much as possible.
Okay, thank you very much. So the next poster is on seeking routinely collected data to determine if there is differential uptake in NICE recommended weight management interventions. And this is going to be presented to us by Jean
Sorry,
Massanieri.
Patrick, we've got another video for Carol.
Okay, another video for Carol. So
Yes,
we'll just
she has
run this.
two presentations.
Okay,
Great,
let's run
thank
this.
you, Fiona.
It's
Can you
okay.
play?
I'll play the second video now.
Okay.
Hello, my name is Carol Lenny, and on behalf of my co-authors, I'd like to present our study called Overviews of Reviews, Informing Clinical Practice Guideline Development, a meta-epidemiological study. So overviews of reviews synthesize the results at the systematic review level, much in the same way that a systematic review synthesizes the results of randomized control trials. So overviews inform clinical practice guidelines and government health policies, although the extent of this practice is largely unknown. As one example seen here on the right, Australia's Private Health Insurance Act of 2007 was changed in 2019 based on an overview of 16 natural therapies which found them to be ineffective. The impact of this overview was vast. 54% of Australians have health insurance, and eliminating the rebates saved the public health system millions. Overviews informing guidelines should be fully reported to assess the methods and the biases. So here's an example of an overview of health policies. This overview examines the effectiveness of different interventions on the same condition, namely tuberculosis. It contained 45 systematic reviews. So for our methods, we searched Medline, Epistemonicus, and Cochrane databases. We included overviews citing that they had informed a clinical practice guideline, and we compared these to traditional overviews of reviews. For our results, we found that 16 overviews directly informed a clinical practice guideline, and we compared these to 77 traditional overviews of reviews. Overviews informing guidelines included less systematic reviews compared to overviews of reviews. And you could see that in this graph here at the bottom. So in both groups, methods common to both overviews and systematic reviews seen here in Table 1 were more frequently reported than methods that were unique aspects of overviews, which is seen here on the right. Methods pertaining to more unique aspects of overviews were considerably underreported. So in conclusion, overviews are an efficient method to synthesize systematic review data to inform guidelines. However, substantial improvement is needed to increase the transparency of the methods used in overviews of both types. All right, Patrick, it ended right now.
Okay, so thank you, Carol, again. I see that there are no questions for you in the live Q&A. I'll quickly just check the discussions. No comments there for you as well. So I think a quick question has just come in for you. I agree that overviews are an efficient tool. However, do you think that this is even more problematic than if this is even more problematized by GIGO?
Pardon?
Do you think, I don't know if that's a typo or it's an abbreviation? Donald, maybe you clarify that and we can come back to that.
Great.
Okay, garbage in, garbage out. Okay, so do you think, so it says, I agree that overviews are an efficient tool. However, do you think that this is even more problematized by garbage in, garbage out?
Oh, I see. Okay, well, as I said, it's the same problem for every type of evidence synthesis. So whether it's like, a scoping review, it could be a rapid review, it could be like a systematic review with pairwise meta-analysis, where meta-analysis is only comparing two things. It could be, a systematic review with network meta-analysis, or an overview of reviews, right? Those are all different types of evidence syntheses, and they all suffer from this problem of, garbage in, garbage out. So we have to do the exact same method, the exact same thing for every different type of evidence synthesis, where we have to make sure that we assess the risk of bias of all of those, primary studies. And what I mean by primary studies is like, randomized control trials or cohort studies or case control studies, case series. We have to make sure we assess the bias of these studies. And we have to make sure every single time we write up our results and our conclusions, we have to say, hey, listen, we found, that these studies were at low risk of bias. And then there was only, say, a few, or there was maybe half of them that were high risk of bias. So we're going to base our results on these high risk of bias these studies that were high quality. So we're only going to talk about the high quality studies, or, we're going to take into account these low quality studies, but we're going to have caveats that those effect estimates are going to be overinflated.
Okay, thank you. Lots of questions coming in for you. I'll have to check how we are doing on time, but I'll quickly take them. So a question from Therese, compliment you for a presentation, then says, how did you assess the quality of overviews of review?
Such a good question, actually, because there's no way to do that right now. So I was thinking about this last night, actually. It's like, how would I assess, like, I've done overviews now for, over 7 years, maybe longer, actually, and this is my sort of focus. But what I would do is I would just, I would assess an overview, since there's no tool now to assess overviews. I would assess it using the Robust or the AmStar tool, and which are tools to assess systematic reviews. That's what I would do first. And then what I would do is I would look at the unique aspects of overviews. So those are overlap in the primary studies. That's one unique issue. There's also the issue of discrepant results across systematic reviews, right? So those are the two most obvious ones. There's a lot, actually. There's 5 other unique aspects. So what I would do is I'd go back and make a judgment. Did those authors do a good job, say, looking at overlap and taking into account overlap in their results? So that's what I would do for every unique aspect of overviews.
Okay, thank you very much. So another question for you from Aiton. He says, is the Prisma a good tool to identify these possible bias that you have highlighted in the overviews?
Sorry, is what a good tool? Which one?
The Prisma.
Oh, so okay, so Prisma, so there's different types of tools, right? So Prisma is about how well you've described the study when it comes to publication. So you need to have this really well described, the methods and the results super described, in order for me to go ahead and assess the bias or the quality of the actual systematic review, right? So Prisma is only about how well described the study is. It has nothing to do with the quality of the study or the biases that are in the study. So to assess the quality or the biases, you would use the AmStar 2 tool to see how well it's conducted. And then to assess the biases, you would use the Robust tool. So those are my recommendations.
Okay, and one last question from Donald. What then does this say about past and current primary research? I'm not sure how that connects. Can you figure this out, Carol?
I can answer that. Yeah. So how does that? So you're right, Donald. Like, there is a lot of bad quality studies out there, right? Like, there's this huge, John Ioannidis wrote the huge paper about research waste, right? And which is, very well cited, just to say it, to be understated about it. But yeah, waste of research and doing these low quality trials is a huge problem. But if you're creating a guideline, if you're writing, a systematic review, it's I think it's our jobs as people writing these systematic reviews and guidelines to say, hey, listen, we need better trials, and this is what we need. You know, you need to report, you know, these methods better. You need to, you know, have 400 or more, you know, participants in your trials. You know, so we have to make recommendations. Not only that, but we should do advocacy around that. You know, like with Ben Goldacre, who wants to have more transparency in how trials are reported, and he wants to increase the quality of trials. So we should get on board with like these types of initiatives.
Okay, so we have several more questions in the comments, but I think for the interest of time, we will move to the other speakers and we can come back to the questions.
Okay, thank you, Patrick. And also anybody with questions could also email me.
Okay, great.
Thank you.
Okay, so the next poster is seeking routinely collected data to determine if there is differential uptake in NICE recommended weight management intervention. And this is from Jean Masaniero. Jean is a senior technical analyst at NICE, working in the Center for Guidelines, Methods and Economics team for the past 3 years. Prior to this, she worked in public health as public health analyst in local government. She holds a Master of Science in Epidemiology and Biostatistics and currently completing a Master's in Public Health from the University of Liverpool. She has a keen interest in public health. Jane, you have the floor.
Can you see my PDF?
Yes, we can see that.
I'll just make it slightly bigger and scroll down. So apologies for the long title, but you know, that's the best I could come up with. So it's seeking routinely collected data to determine if there's differential uptake of NICE recommended weight management services. So we wanted to assess if there is differential uptake of NICE recommended weight management services, because we know that in some cases, public health interventions exacerbate health inequalities in the general population. As we all know, health inequalities are unfair and avoidable, and reducing them is a core element of the new NICE strategy. So to help us assess whether there is differential uptake of weight management services, we needed to firstly determine the availability of routinely collected data on either prevalence of obesity or overweight, or provision or uptake of weight management services. So to do this, we carried out a pragmatic search to identify data sources, including audit data. So mainly we're looking at routinely collected data. So we had a look at all the NICE weight management recommendations, and we're able to categorize them into 3. So we had the lifestyle and behavioral interventions, pharmacological interventions, and surgical interventions. We found that there were 3 main data sources in England that provide data on the prevalence of obesity or overweight. So the National Child Measurement Program data, which provides for children, and then the 2 surveys, the Active Life Survey and the Health Survey England, providing data for adults. And surprisingly, these data sources showed there was differential prevalence of obesity or overweight when data was analyzed by socioeconomic status, disability, ethnicity, and deprivation. There was no centralized data on lifestyle or behavioral interventions. So therefore, we could not assess the impact of NICE recommendations offering lifestyle or behavioral interventions as their recommendations. And then for surgical and pharmacological interventions, hospital episode statistics showed that obesity-related hospital admissions were highest in people from the most deprived areas. And similarly, there were more Orlistat prescription, which is the pharmacological intervention in the NICE recommendations, were mostly provided for people in the most deprived areas compared to the other levels of deprivation. So based on this, we could deduce that pharmacological and surgical interventions are provided to the groups that have the highest prevalence. However, we're still not able to identify any data on primary care service provision. So we could only partially address the aim of the project. So now, to fulfill our aim, we are now carrying out phase 2 of the same project, approaching local authorities in the northwest of England, asking if they have any relevant data on the provision of lifestyle and behavioral interventions at local level. Thank you for listening to my presentation. Are there any questions?
Thank you very much, Jane. I'll just quickly check if there are some questions for you in the question and answers. And thanks to the participants for actively asking questions. I encourage this to keep coming, but we will try to ensure that we can have all the speakers present. So we have a question for you. I think I saw a question pop up here, but I'm not sure if this is for you. I'll just try to see the most recent ones. I think these questions are not directed to you. So we will come back. These are legacy questions for Carol, which we'll probably come back to. So we will move on to the next speaker, but if you have any questions coming up for Jean, please keep them and we will bring them back to her if we have time at the end. We have 7 more speakers to go, and if we look at the 3 minutes each, that comes to about 21 minutes. So we have about two minutes per presenter for questions. The next poster is on equality impact assessment of NICE guidelines, understanding the approaches to address health inequalities. And our presenter is Peter Shim, and he's a senior analyst at NICE. Pete is senior analyst in the Center for Guidelines at NICE. He has worked on the development or surveillance of guidelines at NICE for the past 13 years. So Peter, you have the floor.
Hi there. Can you hear me, Patrick?
Yes, I can hear you loud and clear.
And you have my slides?
Yes.
Great. Okay, I'll start then. Hello, everyone. My name is Pete Sheehan. I work at NICE, and I'm presenting this project that I co-authored with Leslie and Swapna, who are on this session as well. So the project was looking at how the quality impact assessment is used within NICE guidelines and looking at other approaches for considering and addressing health inequalities. Okay. Okay, so we undertook this piece of work as a research project, and we used semi-structured group discussions. We had 9 groups across a total of 25 staff in the Centre for Guidelines, and each of those groups had different functions, so they may be developers or surveillance or commissioning teams. We had a number of different discussion topics. It included what they thought the purpose of the quality impact assessment was, and how they used it or how it's used, challenges in using an assessment tool, and in addressing health inequalities more generally. And we also got participants to discuss suggestions for future improvements to quality impact assessment and what the training needs were for them. So I've just got a snapshot of some of the results from the work here. First, the quality impact checks were recognised as being an important influence on guideline development. It drove and encouraged developers and committees to think about equalities issues and help them to identify and respond to those issues. Second, the participants expressed some uncertainty in the best way to identify health inequalities or equality issues. This relates in part to the outcome we've identified. There was some variability in practices. The EIA tool itself does give some guidance, and NICE methods manuals also provide some important information about what is needed to be done, but there was a need for greater clarity on how to go about this. Participants identified they never received any formal training or specific guidance for EIA completion, and this is recognised as a gap. So I just want to run you through a few of the proposals that come off this project. First and foremost, I think we recognise it be important to have better integration of equalities considerations throughout the guidelines development, throughout its guideline development cycle. there is a need to allow more time during committee meetings and progress meetings to discuss equalities and have those considerations as standard agenda items. Second, there's a need to develop a better EIA approach that's actually built into the guideline. So where you've got recommendations and background rationale to the recommendations, there needs to be explicit mention of any equalities issues, or even if there were no equalities issues, to clarify that and specify that so people can respond to that. And third, to make better use of stakeholder consultations. NICE uses consultations at various stages of guideline development, and we need to ask specific questions about equalities and health inequalities to our stakeholders. And lastly, there's a need to prepare a support document which clarifies best practice for developers. And this is some piece of work we will undertake as the next stage of this project. So thank you for listening. If you have any questions, please send them now. And you can also send me by email if you have questions after the session.
Okay, thank you very much, Peter. I don't see any questions in the question and answers for you. Let me check the discussion board. Apparently, Carol had swallowed up all the questions. Okay, so no questions, no comments in the discussion board at the moment. So we will move on to the next post-term, and which is how will big data and real-world evidence serve the future of clinical practice guidelines? And this is presented by Jiang Wang. She's a master's student at the Lanzhou University. Jiang is a master's student at the School of Public Health in China, whose tutor is Professor Yao Leng Cheng, the executive dean of the Lanzhou University Institute of Health Data Science. The main fields of interest are methodology of systematic reviews and clinical practice guideline development for reporting guidelines, knowledge translation, health big data, and evidence-based medicine. At present, more than 20 journals, articles, and international conference papers have been published from their work. Jiang, you have the floor.
Hi, ladies and gentlemen. I'm a student from Lanzhou University in China. My topic is how will big data and real-world evidence serve the future of clinical practice guidelines? Nowadays, clinical practice guidelines have become widespread in every field of medicine, and they are largely based on the results of traditional randomized controlled trials and systematic reviews. Therefore, clinical practice guidelines often suffer from a gap between trial efficacy and real-world effectiveness, which is one of the common reasons contributing to poor guideline adherence. In order to explore how to apply big data and real-world evidence in the development of clinical practice guidelines, we plan to search the guidelines of using big data and real-world evidence, especially eligible COVID-19 guidelines, and analyze their application status at length. Combined with expert interviews and modified dolphin presence, further to clarify the role of big data and real-world evidence in the evidence flow of decision-making, and identify in which situation they can provide evidence to support guidelines. However, after our pre-test, we found that the number of eligible COVID-19 guidelines is insufficient. So we intend to convert the target disease to lung cancer, which is the cancer with the largest disease burden in the world. Currently, this work is still in progress, and we know big data and real-world evidence, generally in the form of data from integrating electronic health records, always represent the experience of doctors and patients in real world. They have the potential to fill the gap in current guidelines by completing information about whether some treatments really work with comprehensive and real-time data. This will benefit to decision-making in evidence-lacking situations, even evidence stirrers in emergencies, and enable guideline developers to more precisely and timely determine not only whether a treatment is recommended, but also for whom and when. That's all. Thank you.
Thank you, Jan, for the great presentation and the good timing. And really appreciate the fact that you were able to wake up at this time of the night for you and give this very interesting talk to us. And you have a great team out there. I think I've met in one of the conferences with your professor. So I don't see any questions in the Q&A for you. But if there are questions, we will come back to you with these questions. Let me check in the discussion groups, discussion forum to see if there may be any comments there for you. No comments in the discussion forum. So we will move on to the next speaker, the next poster. The next poster is Lily Wei. And her poster is maximize the generalizability of 3 heart failure randomized control trials by calibrating the trials to a heart failure register in Scotland. And Lily Wei is a student at the University of Glasgow. She has an MPH and a Bachelor's of Medicine. Lily Wei, if you are present, we will be happy to have your presentation. Thank you.
Thank you, Patrick. Hi, everyone. I'm Lily Wei, a PhD student from the University of Glasgow. I'm going to present assessing the applicability of 3 heart failure trials by calibration to Scottish registry. Heart failure is a life-threatening disease of cardiac functional impairment, usually associated with a poor prognosis and reduced quality of life. RCTs are the gold standard with high internal validity to explore the causal relationships in medical interventions, as well as in heart failure treatment. However, patients in the real world can be relatively more elderly with more comorbidities than those in trials, raising questions about the applicability of trials to real-world populations. Our objective is to calibrate trials to better reflect routine clinical practice without breaking randomization. We use 3 trials and one Scottish heart failure registry as showed in the poster. We then applied these 3 trials into the Scottish registry to re-estimate the treatment effects. The first calibration method is the regression-based method. We used parametric survival models, and it requires individual patient data from both the trial and the registry. The second method is the inverse propensity score weighting method. We used logistic regression with the individual patient data from the trial and the aggregated data from the registry. For the results, patients in the registry were older than trial participants and had lower eGFR levels, which is a measure of kidney function, and higher furosemide dosage. In each trial, as shown in figure 1, effect estimates from uncalibrated and calibrated analysis were similar. Finally, as you can see from the confidence interval, the calibrated estimates for all 3 trials were no more than 1.5-fold less precise than the standard estimates. Our findings show that calibration may be used to estimate the applicability of clinical results to populations typically encountered in clinical settings, with only moderate losses in precision in the treatment effect estimates. Thank you. I'm happy to answer any questions.
Thank you, Lily, for your great presentation. I think you have a question in the Q&A from Karen Robinson, and she would want to know, first says, very interesting presentation. Could this approach be used with IPD meta-analysis? Also, is there a publication link for this you can share?
Thank you for the question, Karen. I think, yes, we can use for the IPD meta-analysis. We will publish it soon, so you can keep an eye on my publication.
Okay, thank you. No more questions there for you. Let me check the discussion box if there are any comments popping up there. So there is nothing in the discussion box. Okay, so we would move on to the next poster, which is an analysis of requests on guideline-related topics received by NICE International. And this is from Hugh Maguire. He's a senior scientist advisor at NICE. So Hugh is a senior scientific advisor within the NICE International and NICE Scientific Advice team, and he leads technically on the NICE International services with specialist knowledge of guideline development. Who do you have the floor?
Hi, thank you, Patrick, and thanks to you all for coming along this afternoon, evening, morning. It's my pleasure to present this analysis based on the request that NICE International have received since it was relaunched in 2019. I'd like to thank the people in my team I worked with who helped produce this. So, as you may know, NICE International was relaunched as a not-for-profit part of NICE, in which we would deal with inquiries coming from other countries and other guideline developers around the world. And we would be able to provide them and share our knowledge and experiences and give us an opportunity to learn from other people as well. So we set out to look at all the requests that had come in since 2018 to 2021 in August, and have a quick look at those in some very basic sort of demographics. So we got 58 requests specific to guidelines, and the majority of these were accepted. Some were declined as they, for example, could come from a pharmaceutical industry, or they were withdrawn by the requester. And most of the content that's requested is around sort of how NICE develops guidelines and the processes it follows. And that's not just the meta-analysis and the committee work, but it's how NICE organizes its suite of guidelines of, at the moment, it's over 300 guidelines, and how it keeps them as up to date as possible. There was also some requests for information on quality standards and also the reuse of NICE content, either by getting a license to adapt or to work with NICE to contextualize that guideline. And essentially, that's what has been requested. On our webpage, we ask people to specify what type of work engagement they would like. And it quite often starts with a meeting, but then that does then lead on to other types of consultancy as well, and seminars and workshops. So who is submitting requests? Quite often this comes from national governments or state governments. The most frequent in terms of numbers is the Department for Health in the UK, the Department of International Trade, sorry, the UK, who are often approached by a government ministry abroad for requests for help or assistance in this matter. It also sort of comes via academics or regulatory bodies as well. And some consultancy firms come in and professional bodies, but the majority is via sort of the UK Department of International Trade and other government departments. So what have we done with these requests? We have produced a lot of seminars and webinars. We've met with a lot of people, and we've delivered a lot of speaking engagements at conferences and at national meetings or even departmental meetings. We're at the stage now where a lot of projects were put on hold because of COVID, and we are starting to start up delivering those again now, and we'll aim to finish them in 2021-22. So this is a snapshot of what it is we're doing. The reason that we looked at all of this is so that to enable us to get a better idea of what people would like us to deliver, what information they would like support with, what type of advice they're looking for, and this will then help us deliver a better product to our international colleagues. However, we do need to do a bit more work on it, which will be around sort of the idea that different stakeholders are asking for different types of information. And we also are quite keen to examine the in-country impact of this engagement with NICE International and NICE. So it's one thing saying that a speaking engagement or a seminar went well, but did it actually lead to any meaningful change 1 to 2 or 3 years down the line? Has it had that level of impact? And we'll be looking through that. So that's the end of my presentation. So I'm happy to take any questions you may have.
Thank you very much for your presentation. And I think we do have some questions in the chat. Ye Ching is asking, how do you decide on which requests to accept?
We have a process. A lot of it is down to sort of who is requesting. So we accept the majority of requests, and we are willing to work with people to finesse the request and find out what we can offer to them in terms of dealing with the request. We will also pass on the request to other partners if they are more suitable for handling it. For example, if NICE doesn't have that experience, we will pass that on. We are a small team, so a lot of it is down to capacity as well, but that hasn't been a huge issue in the last few months because of the way we're working now. And I joined in June, so we've got extra capacity. But we are willing to talk with people to find out exactly what it is they want and then deal with it accordingly. But we do accept the majority of requests that come in.
Okay, I think that's good to know, and happy to see that the email contact was there. I think some of the working groups at GIN will be interested, like the LMIC working group and the Africa community. I see there's one country in Africa reported in your results, Nigeria, but I believe there would be more who could benefit from this kind of collaboration. So I'll keep that in mind. We don't have any more questions or comments for you in the chat. So we'll just move on to the next poster, which is, I'm not sure if we have Jeremy now, but if he is there,
we don't have Jeremy.
Okay, so we don't have Jeremy. So we would go on to Swapna, and her poster is on current mechanisms for considering health inequalities at NICE. Swapna Mistry is the project manager at NICE. She's a project manager within the Guideline Surveillance team in the Center for Guidelines at NICE. She is responsible for project management for the development and delivery of guideline surveillance reviews. She has also led on the development of the Center for Guidelines Expert Advisors panel, which she currently manages. She is currently involved in NICE's Health Inequalities Program. She has a master's in public health from the University of Liverpool and is currently completing her MBA at Manchester Metropolitan University. Before joining NICE, she worked as a public health development manager in the NHS and local authority. So up now you have the floor, please.
Thank you, Patrick. Can you see my poster?
Not yet. I don't know if the others see, but
no, we can't see it, Swapna.
Yes,
yes, we see it now.
Can you see it now?
Yes, that's fine.
Thank you. So my poster is about current mechanisms for considering health inequalities at NICE. Tackling health inequalities is a system-wide issue in the UK and a key strategic priority for NICE. The aim of this work was to identify the work that is currently being done, planned and delivered to consider health inequalities across programs in NICE. 2 surveys were undertaken, and we started by contacting all associate directors and team leaders across NICE. This work started in February 2021, and we did a follow-up survey in July 2021. The collective responses of both surveys was, we got a response rate of 93%. This work was led by the Cross-Institute Health Inequalities Program and engaged all teams across NICE to see the work that's happening in this space. So NICE is doing a lot of work around health inequalities. We categorized this work in 5 specific areas around stakeholder engagement, methods and processes, communications, support for implementation, and delivery of training. So the various initiatives that consider health inequalities are delivered through internal collaborations, deliberative engagement, for example, programs like NICE Listens, collaborations with external system partners like Care Quality Commission, in our methods and processes at every stage within the guideline development process. Within our equality impact assessments that are undertaken for all the guidance we produce, the work of international collaborations, using inclusive language, digital accessibility, the impact reports that the field team at NICE produces, engagement with social care providers, and training around health inequalities. So this mapping work is now going to inform how we are going to take health inequalities forward to tackle this agenda, which is a strategic priority for us. So some of the recommendations are that we need to consider how we are going to embed this agenda as a business objective for all work programs in NICE, undertake more qualitative research to consider variations in practice internally within guidance developing teams, and finally, establish a systematic approach for considering health inequalities at NICE by facilitating sharing good practice across the Institute. Thank you. Dr. Leslie Owen and I will take any questions you have. Thank you.
Okay, thank you very much, Swapna. So I understand that Dr. Leslie is not giving a presentation, but will be answering any questions that come up together with you. I don't see any questions in the Q&A, and I don't see any comments in the discussion. And this means we have wrapped up for all our speakers well ahead of time. We still have 15 minutes to go. So I would propose, if we don't have more questions for Leslie and Swapna this time, we could go back to take the questions for Carol. Carol, are you happy to take some questions at this point?
Hi. Yeah, I'm definitely happy to take them. I've been answering them in the chat, but I could definitely answer them here as well.
Oh, great. Okay, I wasn't catching up on the discussions that were going on in the chat. That's really great.
Yeah, I have to say that I really love the way this is set up, where you can go to the questions and you can definitely answer them if you want to, like, and talk to people like by chatting to them. It's a great setup. I love it.
Okay, so I see you've answered most of the questions. And so I'm a bit at a loss what to
All
do.
right. Well,
But,
I could answer some of the questions that are sort of more general.
yes, please go ahead. And then after that, I'll give an opportunity for us to talk amongst ourselves to see what are the connections at the different levels. What can some authors or some speakers gather from what the other speakers had said and stuff like this. So thank you, Carol. Go ahead.
Okay, I guess Teresa said, so I think I wanted to talk more about how to, assess the quality of overviews of reviews, because that's a question I get a lot, but as I said, there is no developed tool to do that. And just like if we were going to go ahead and develop a tool, we would do it very systematically. So we would look at the evidence that's been written and done before about overviews, and then we would kind of compile that together. And then we'd kind of craft a tool, and then we would ask experts, people who do overviews a lot, and methodologists, like how, if they think that the tool contains everything that it should, and, is it worded right? And then we would kind of publish it. But so there's nothing like that right now, but, so I did talk a little bit about how there's a lot of, there's the same methods in systematic reviews as in overviews of reviews, very similar process. However, there are these unique aspects to overviews as well. So I would actually use the AmStar 2 tool, which is used for quality of conduct. So how well, a systematic review is actually done. And then I would use also the Robust tool, which is about assessing the biases in a systematic review. And biases in a systematic review are something like publication bias, where, we know that studies that are negative, have negative results, aren't published frequently. I mean, that's changing thanks to people like Dr. Ben Goldacre, but this needs to happen more often, because in a systematic review, we want all the evidence, right, on a topic. We don't just want the positive results. We want the negative results as well, so that we can get a fair assessment of the true effect of any intervention. So, publication bias is just one type of bias in a review, but overviews also suffer from publication bias, the same as systematic reviews do, but there's two levels to it, right? So there's the level of, was there studies that are missed, that are trials or cohort studies, so primary studies, were those studies missed because, for example, they might have negative results? But then we might also think about missing studies that are systematic reviews. So overviews also might have missed systematic reviews, because there's lots of systematic reviews that also have produced negative effect estimates, negative results. And so those are also not published in the literature. So we have to think about that second level of publication bias that might happen. So all the methods for systematic reviews pertain to overviews, but it's kind of an extra kind of thinking process and an extra level that you have to go through to identify all the biases in overviews.
Okay, thank you. Are there more questions? Okay, there are some questions popping up in the Q&A. So Karen is asking, what about prior, which is in development, and aware about it? Yes. Go ahead.
Yeah, so I'm also luckily a co-author on Prior. So Prior is this very similar. Prior is a reporting tool for overviews of reviews, and so a tool to do that in a systematic review is Prisma, and everybody's very familiar with Prisma. And so Prisma and Prior are very similar. And so what they do is it's kind of like more like a checklist or a standard to see if your systematic review using Prisma, or if you're overview using Prior, you use that to see how well the study is described, right? So in publication. So it's only about how well the authors describe the study. But if a systematic review or overview is really well described, right, then like people like us, or people from NICE who want to, look and see what the quality of a systematic review and over an overview is, it's easy because now everything's really well described by the authors. So assessment of quality and assessment of how well a study is reported goes hand in hand. So we need both. So definitely using prior to see how well the methods were described, how transparent the study was done is very important as well.
Thank you very much. And I think Lucia has her hand. So Lucia, I'm sure you can unmute yourself and speak. And I think as we are talking amongst ourselves, if this doesn't pose a technical problem, we can have our videos on so we can all see those who are talking. Fiona, I hope this is okay. Go ahead, Lucia.
Thank you very much, Patrick. And I just wanted to jump in here because I must say, Carol, that I will be presenting again tomorrow the results of an overview of reviews. And we have used your paper on the overlap, and I must thank you very much for that. It was extremely helpful. Thanks a lot.
Oh, great.
And also that maybe some of you have heard that JBI actually uses a different term, umbrella reviews, and yeah, you just might come across that, and it's basically the same thing. And we have used JBI critical appraisal tool to appraise the risk of bias in the systematic reviews that we included. So yeah, I just wanted to jump in there.
Right. So I don't believe that. So the JBI tool is about it's about quality. It's not about risk of bias. So the only tool to assess risk of bias in reviews is the ROBUS currently. So, but yeah, great. The JBI is a great tool to assess quality.
That's right.
Okay. Thank you, Lucia, for that contributions. Let me just confirm if we have some more questions. We don't have any more questions in the chat or comments. So let me see. So if we don't have any more contributions, then we will probably be having an early roundup. But really, we are happy to have anyone come up with any comments. If we have any hands raised, we will call you to talk, but otherwise we can say it's a wrap. We finished early. We saved about 9 minutes. So I'm sure it's very late in some areas, but very early in some areas. It's dinner time for us, and I have been sitting up for quite a while. I'm sure my little girl has been running behind me, checking on me, what's going on. So I hope we all had as fulfilling time as I did. Otherwise, we can say it's a good wrap. Thank you, everyone, for your great presentations, and I wish all of you good luck in the very great work that you are doing. And
Patrick, can I say thank you for your excellent moderation that you've done today? You've done such a great job. Thank you.
Oh, great. Thank you. I really appreciate that. Thank you. All right. So we can say bye-bye, everyone. Happy to see everyone.
Bye.
Bye-bye.